Hello there, my name's Sophie Roberts. I'm a musculoskeletal podiatrist from London, England, and today I'm going to be talking to you about tips for pre- and postpartum musculoskeletal pain from a podiatrist's perspective. So a little introduction and some of the things we're going to talk about today is the effect of the feet, the effect of pregnancy on the feet, and common foot problems that we see pre- and postpartum. We'll talk about how we can manage some of these foot problems and to manage the pain. We'll also talk a little bit about the effects of gait during pregnancy and how that may change. And of course, the most important thing is it's all about the footwear. So we'll talk quite a bit about that today. So it's very important, particularly for patients with hypermobility, to keep mobile and also to manage deformity progression in their feet. And so managing foot pain is a very important part of this. So pathologies or problems with the feet, foot and ankle present as a result of changes either in foot structure and function or due to changes in the walking pattern. Just to note, I know we're talking about more musculoskeletal pain, but it's important to be aware that nails can either grow more or they can actually deplete. So it's either way. So there could be problems with nails sort of breaking, or it could be more sort of ingrown toenails, but that sort of thing is important to manage as well. The other thing as well, particularly with the hypermobility patients, that symptoms can become more problematic. So all the things that we see, perhaps skin fragility, sweating, poor proprioceptive control or cramps can become perhaps more exaggerated during pregnancy on top of the actual kind of musculoskeletal pain. So we see an increase perhaps in laxity in pregnancy, which obviously if patients are already hypermobile, this can become more of a problem. Relaxin hormone causes changes to soft tissue structures, basically in preparation for the body for labour and accommodation of the growth of the baby. And with that, the relaxin hormone can affect the ligaments in your feet and can cause changes which may then increase shoe size due to foot elongation or spread, or perhaps some structural changes in the feet. So you might see maybe more bones poking out in the inside of the arch, or the little toe joint or the big toe joint. And also we know that in patients with hypermobility, ankle sprains can be very common, and this perhaps can be more common in pregnancy, perhaps due to the centre of mass change. So again, a change with that change in gait and change in sort of GPS, I call it the proprioception. So with the changes in foot structure, this can affect function and it can cause new pathologies or new problems. The increase in body mass index, which is a natural thing that happens, changes the force to the structures on the feet. And foot problems or changes in function of the feet can cause pain and stress, not only in the feet, but also further up the biomechanical kinetic chain, as we call it, up to the knees, hips and back. So the common foot problems we see in pregnancy will now be presented. So plantar fasciitis, heel pain, or plantar fasciitis is a painful, inflammatory, or sometimes actually non-inflammatory process of degeneration of the plantar fascia. The plantar fascia emanates from the heel and fans out and inserts into the base of the toes. And as the foot structure changes or elongates, we tend to see more stress to the plantar fascia, which can cause pain. But also, it's important to remember, not all heel pain is plantar fasciitis. Plantar heel pain, you can get plantar heel pain bursitis, maybe some bone stress to the calcaneum, which is the heel bone, or perhaps nerve pain in the feet. So it's important to rule out what the diagnosis is. So Achilles tendinopathy is an overuse injury to the Achilles tendon, which we sometimes see more in the kind of mid portion, which is that bottom right hand picture there, or actually at the insertion as it inserts onto the heel. And the calf, it acts as a stabilizer of the foot. So quite often you can have quite marked joint hypermobility in the feet, but then a very tight calf muscle because the calf muscle is trying to kind of gain that stability. Also, there's the aspect of the fact that the calf is maybe not strong enough to cope with the increase in the body mass index that you have in pregnancy. So that can put perhaps additional strain on that whole area. So bunions or hallux abductive valgus deformities, where you get deviation of the big toe and a high intermetatarsal angle, so the angle between the kind of first and second toe. It's very common in hypermobility, and arch mechanics, so arch profile, flattening the arch, can be a causative factor. And it can progress further in pregnancy, again, due to that relaxin hormone, change in soft tissue structures, maybe causing more splay. Also, increased foot volume, which we'll touch on later, due to swelling, can also aggravate. So if the shoes are a little bit tight pre-pregnancy, and then during pregnancy the feet swell, that can put pressure on the bunions or the metatarsal problems and subluxations and the met heads. These are sorts of things we see commonly in hypermobility. Intermetatarsal neuromas, which is the scar tissue and irritation of scar tissue on the nerves that run between the metatarsal heads. We see these digital retractions for stability, and perhaps splaying of the forefoot due to increased body mass index. So again, we can see some changes or pathologies in that. So the other aspect as well is we talk a lot about maintaining strength and conditioning with management of hypermobility. With hyperemesis or morning sickness, disuse of the muscles can result in this deconditioning, or it can result in the inability to engage in the normal exercise routines. There is also the aspect of the kind of more dehydration and nausea, which can affect the POT side of hypermobility and also increase fatigue. So it's more the fact that, you know, if you're feeling sick all the time, you don't feel like doing all your strengthening, and therefore the muscles are perhaps deconditioning and not able to support the joints. And then moving on to fatigue, and we know that pain and fatigue are major clinical manifestations in patients with EDS and HSD. So managing that fatigue during that very difficult time can be even more difficult for these patients. So the management of foot problems during pregnancy, we really want to be looking at conservative management. Conservative means nothing interventional. Sometimes we're just using temporary management strategies, such as padding, taping, and footwear changes, which we'll talk about later. But it's an important part of making sure that the feet are comfortable, then they're able to be more active, and managing the other aspects of their hypermobility, as well as obviously mental and physical health. So one of the mainstay treatments in podiatry and for managing foot pain are insoles for musculoskeletal pain. And there's different types. There are over-the-counter insoles, which you can buy on the internet or in shops. Then there's the podiatrist prescribed stock insole, which is not a fully customized one, or can be customized with additional features. And then there's the custom-made orthotics, which is probably not ideal to go down that route during pregnancy, because we've talked about the changes in the foot structure. However, obviously, if they're already wearing them, this is definitely the time to be wearing them as much as they can. So the features of orthotic and insoles is the shell, which is the kind of more rigid part towards the kind of rear foot and arch, and then maybe top covers and external modifications like metatarsal pads or areas to kind of accommodate and offload maybe areas in their kind of forefoot. But the most important thing is they are comfortable. That's the number one rule. So comfort, comfort, comfort. So if we're doing a casted orthotic, or the process of this, I just thought I'd pop this slide in here. We take a cast of the foot or a digital scan of the foot in clinic. This is then modified at the lab, and then either the foot is the corrected foot is milled out of MDF and the insole made around that, or the insole is 3D printed. So that's just to kind of show you the process of having something custom made. But the importance of orthotics for the hypermobile patient is that they sometimes have a different loading characteristic due to the connective tissue disorder, perhaps higher pain levels than in normal biomechanical patients. So we maybe are going to more like the softer, more accommodative orthotics. Sometimes they've had previous bad experiences, which is why it's important to try different types or try a different podiatrist. But, this is sometimes a really important part of their treatment plan. So interventional treatments, as I said, are sort of best avoided. Injections, cortisone, surgery, imaging considerations. Do you want to be doing x-rays if there's that exposure to radiation? However, we must remember there are certain urgent situations where certain interventions are definitely needed. The other nice way of managing foot pain is using braces and splints to help alleviate biomechanical stress. So the kind of toe joints, the toe splints. There's the ankle splints, there's this X brace, which is the one at the top with the kind of going over the top of the arch. And then we can also use toe props to kind of offload sore toes, or to actually offload forefoot by taking more pressure under the toes. So padding and strapping, and these are really good, nice temporary relief using semi-compressed felt, which you can, buy online. Using a zinc oxide tape, which is the tape in the right-hand corner there, or a K-tape, which is a more stretchy tape. And essentially what it does is it offloads or cushions certain areas of the foot. It can support the arch. And it also, particularly if they're in a summer pregnancy, can be used with sandals. So you get the support, the tape and the padding that you would have with maybe orthotics and trainers, but you can allow the foot to kind of splay and expand with any foot swelling. The video on the right is just showing an example of kind of foot taping of the arch, and how you kind of can use this tape to really try and create some stability within the foot. So those go around the rear foot, and then the pieces of tape that are just lined up on the right-hand side there go all underneath the arch and can give the foot some really nice stability. So they just go all under there, lots of those, just to really hold up the arch. So footwear. There are therapeutic properties of footwear, providing cushioning, support, proprioceptive input. It's important to look at the upper and the sole for what we need in terms of whether we want a good tight fit with a knitted upper, or a nice thick sole, or actually sometimes a thin sole to help a bit with proprioception. We need a good toe box fit. Heel height, maybe not too flat, but not too high. And if there's insoles, we need removable insoles to fit the orthotics. Sometimes we use more rockered footwear for pain in the forefoot to help rocker forward, or if there's any maybe problems with the back, then sometimes actually some rockered footwear can help. So footwear routines pre-partum is accommodating foot swelling. Slip-on footwear may be easier than trying to tie laces. Perhaps you might consider more supportive footwear than normal, and also wearing shoes in the house, or at least during sort of prolonged domestic activities, to allow the foot to have some support. The effects of gait in the third trimester, we call it the waddle. So we end up with this sort of wide base of gait, perhaps reduced ankle power because we haven't got that good forward momentum, and increased step duration because basically the cadence of the walking is slower. And sometimes we see this increased lateral sway of the hips to create that forward movement, and also just because of the position of the baby in the pelvis. Ankle swelling, as I've said, is common, and it's caused by your body holding more water than usual when you're pregnant, and this water tends to gather in the lowest part of the body, i.e. the feet, and particularly is affected by hot weather. And also the pressure of the growing womb can also affect blood flow in the legs. So elevation and remaining active and using that calf pump is a good way of managing it. Varicose veins during pregnancy, the amount of blood increases to help support the baby, developing baby, and puts extra strain on the veins. And also the hormone levels can affect this, and again, compression socks are a good way to manage that. So common foot problems here postpartum, we obviously see the ones that we mentioned but we see a lot more kind of tendon overload, where you're perhaps on their feet a lot more, walking around trying to get the baby to sleep, some bone stress injuries, ball of the foot pain, perhaps there's been some changes to the foot position, and also the heel pain is very, very common. So again, really you're looking at conservative management again, using these maybe temporary management strategies to get them through this. We can actually start to maybe consider invasive treatments, maybe kind of more cortisone injections if needed, but also remembering to try and rest a bit more. So the challenges in managing hypermobility postpartum, particularly from a foot pain point of view, is about recovering from birth, maybe deconditioning due to the changes in exercise routine. Sometimes the kind of positions you get in with handling baby can cause some of these musculoskeletal symptoms. Sometimes it's difficult to get to healthcare appointments, and also, the financial implications of doing Pilates and physio and everything, which is expensive, particularly if you're not working. So these are definitely some challenges that are perhaps more apparent in patients with hypermobility. So footwear postpartum, the comfort is the key. and also looking at the suitability of footwear for the activity. So it's easy to kind of sort of slop around in flat shoes and then to maybe go out for a walk in the buggy, but actually with the buggy, but actually being on your feet a lot is perhaps putting a lot of strain on the feet, and therefore that's the time to use perhaps more supportive footwear than trainers. So sometimes it's not trainers what you want to wear all the time, but this may be a time. And as I said, at home, because you tend to spend a bit more time at home. And also I'm saying in the night, because if you are standing with your arch pain or heel pain and you're standing rocking for hours in the night trying to get the baby to go to sleep, then actually maybe just popping some sliders on, putting some supportive footwear on would be a bit more helpful. So people often ask, when do you change orthotics postpartum? Because there are foot changes, and what I tend to say is it's more 3 months postpartum or 3 months after finishing breastfeeding, because we still see those hormones in the body. Obviously it's symptom dependent, so if someone is really struggling with their feet, then it might be you might recast or start orthotic therapy a bit sooner. And what I mean by the shell fit needs to be assessed is if the feet have changed and spread a bit, then they may not fit their old orthotic shells. It might be that they actually do. So it might be as well that additional features need to be added to the orthotics. So maybe more cushioning, a higher arch height, maybe some metatarsal pads, which are that kind of teardrop shaped pads that go between behind the metatarsal head. So these are things to consider, that it might be you don't need a new orthotic, it might be you just need some prescription changes. It could be that the feet have changed quite a bit and therefore need to be recasted. So these are just some things to have a think about if you are someone that uses custom-made orthotics. So moving on to a case report, which is one of my patients who I've seen sort of over the years. So pre-pregnancy, I saw her and she was diagnosed with hEDS. She had orthotics prescribed for arch pain, and ankle instability. So she was a real recurrent ankle sprain patient. She was very well managed with excellent physio input. She then discovered very gentle but regular Pilates. And she was on a relatively even keel, managing our hypermobility well. And this is something I talk about a lot with patients in terms of it's not necessarily fixing all the problems, but it's learning how to manage them. And with, the right footwear, the right orthotics, and good physio input and regular Pilates, she was managing well. And she did have real concerns about how she would cope with pregnancy, because it was something that she wanted to start a family. So then I saw her actually about halfway, 3/4 way through her pregnancy. Her pain had really escalated. So again, we talked about patients with hypermobility having a bit more susceptible to pain, and actually in pregnancy, her pain really escalated. She developed some hip and back problems, which she had had a bit of before, but this all kind of came at her. She couldn't do the Pilates anymore. She was really struggling. She was sort of becoming quite fatigued and deconditioned, and she couldn't go to physio as much either. So she'd kind of fallen off the wagon in terms of her kind of, maintenance, essentially. She also forgot that she should be using her orthotics at home, or not forgot, but didn't really consider this. And actually her foot pain became worse because she was often wearing orthotics when she went out, and therefore she was not using them so much because she was spending a lot more time at home. So postpartum, she did really struggle, but she managed to kind of rein it all back in again. She ended up actually with 2 spinal epidurals for her back pain. That wasn't to do with epidurals during her birth. This was more pain management afterwards. She ended up having to have a hip arthroscopy and a psoas release. She felt much more unstable in her ankles, and I do wonder whether that relaxin hormone may have changed a little bit with that ligamentous structure. She was more limited with her walking, and she was definitely able to walk a lot less. So what we then actually progressed her onto, she really felt her proprioception had really got a lot worse. So we actually made her a bridge brace, which is an ankle foot orthotic. Essentially, it's a deep orthotic with 2 uprights up the side, which give that stability. That made a huge difference. It gave her the confidence to get out and walk and go to the park, and to be a bit more active. And she then managed to sort of restart a bit more of her physio and restart her Pilates, and got herself back onto that even keel again. So, really difficult time. And she really felt the effects of her pregnancy affecting her hypermobility and the management of it. But, it's just applying all those rules back again, all those kind of management strategies, and just getting the support from all her healthcare professionals that she was under. Thank you very much for listening.